Hi, this is Chuck Gallagher. My guest is Valda Ford. You've heard that a million times if you've been watching this series on men's health, especially prostate health. Valda, we talked about my diagnosis as a person with prostate cancer, or formerly with prostate cancer, and the four options the doctor suggested to me. We just completed talking about active surveillance, or as he called it at the time, watchful waiting.
Right.
One of the other things that he suggested was two different forms of radiation as a possibility. So perhaps we can talk about that in general, and let me say this on the front end, and I think you'd agree. Valda's not a doctor, she's a registered nurse, and I am not at all. I'm just a prostate cancer survivor. So I think our suggestion would be to get detailed medical information. Absolutely talk with your medical provider. And certainly there are a number of qualified websites that you can go to that will give you detailed information. Mayo Clinic, MD Anderson, Johns Hopkins, as well as the American Cancer Society, etc. But let's talk a little bit about radiation treatment as it relates to prostate cancer.
Okay, well, there are a couple different ways of getting radiation. Of course, there's that broader radiation therapy. I want to talk this time, though, about seed implantation. So it's called brachytherapy, B-R-A-C-H-Y, brachytherapy. And what they do is they use a seed that has been irradiated. It's about the size of a grain of rice. And they can put that specifically in the prostate. They can use ultrasound to tell where to put it.
Right.
And there are two different ways to do the seeds. You can do a seed that has a lot of radiation to leave in a short time, or you do something that takes less radiation but leaves it in longer. And so that is actually the preferred way of having a slow and gentle radiation, so they can look at it and see that it's getting what it needs to get but not getting too much. Because anytime you use any therapy, the goal is to retain as much function as possible and to not damage any more of the tissues, the prostate specifically, or the surrounding tissues because you're doing too much.
When I was diagnosed, of course, when I've said this before, the doctor said, well, I'm going to recommend surgery. That's the gold standard. And I immediately thought, is there a platinum standard?
Yeah.
Anyway. But he said, you know, here are the four therapies. And of course, he mentioned the two forms of radiation. Mm-hmm. And he said, however, I would not recommend that for you. He said, you're young. He said in most cases with someone your age and size, because size is an impact for surgery, we could remove the prostate. That will remove the problem completely. And if there ever was a problem in the future, you always are preserving the option of radiation. Mm-hmm. And again, I'm not a doctor, so to be crystal clear with this, I've evaluated over time with multiple sources what I felt was best for me, and this was again back in 2005, and ultimately chose surgery. Fascinating was, of course, after surgery, the PSA dropped to nothing because there was no prostate, so nothing to produce prostate-specific antigen. Mm. And I thought I was fine. I thought it was great, no problem. And I want to say, let me think about this for a second. I'm going to guess it was sometime latter part of 2013. I'd applied for some health insurance, mm-hmm. and the health insurance company said no, and I was like, what? I mean, you know, I think good health,
yes.
And you know, I'm having a regular physical, mm-hmm. and I have my PSA checked, and the doctor doesn't say anything, and it's, you know, we're good. Mm-hmm. They said, well, the chance you live in 20 more years is slim. I said, why? And they said, well, your PSA is going up. Now, Valda, I was like, what are you talking about? I've been going to the doctor and having my PSA checked, you know, every 6 months.
Right.
So I go to my doctor, internist, mm-hmm. and I said to him, I said, let's take a look at my records. I just got turned down for life insurance. And he says, okay. He said, they said the chance that I'm going to live 20 more years is slim to none. And he said, oh, that's crazy. He said, your PSA is great. It's only like 0.8. He said, for a man your age, that's a wonderful PSA. Val and I looked back at him and I said, that's true. If I had a prostate. And I don't know how to describe this, but you and I are friends. I'm going to tell you, that man went white. I'm white. He went white. He was like ash. Because it was one of those moments that hit him that was like, I'm looking at his PSA numbers thinking he has a prostate and didn't go deep enough in the file to remember, oh, back in 2005, a whole bunch of years ago, it was removed.
Right. Well, the interesting thing is that even though there is the attempt to remove all tissue and the surgeon thinks that it's all removed, there might just be a little bit. And those little tiny bits of tissue can produce that very same result. So it's not really super unusual for a person who's had a prostatectomy to have the prostate removed to later see their PSA levels rise. Now, that can be because of any number of reasons, but it's still not, it wasn't reasonable for those insurance people to tell you that, you know, you're on a banana peel slipping into death's door.
Well, you know, you're 100% right, and it kind of freaked me out. But, you know, here's what happened as a result of it, and this ties back into our discussion of radiation. And I'm going to go a couple of different tentacles.
Sure.
But it was like, oh, it's 0.8. Huh. Well, needless to say, I decided I was going to change internist because if you are not paying attention to my medical records, we've got a problem. You're seeing too many people too quickly, and I'm not important.
Yeah.
Went to another doctor. My PSA was rising. 0.8 went to 1.0. Ooh, should have been 0, or functionally 0. Went back again, it went to 1.2. Now, this watchful waiting active surveillance is saying, ooh, I'm on a rise.
Right.
And you're 100% right. Probably, and this is now layman's terminology, but to leave the exterior of the prostate so that the nerve bundles could be maintained so that there could continue to be sexual function meant that probably somewhere there might have been that little cancer cell that decided, oh, I'm going to wake up now and show myself and let you know I'm still here. At that point, then I actually traced down my surgeon from Johns Hopkins, who Dr. Lee Ming Soo, I'll never forget him, who now is head of robotic surgery at the University of Florida, and let him know here's what was taking place. He then recommended a radiation oncologist so that we could talk about the possibility of using radiation as a secondary source to eliminate any remaining active cancer cells.
Yeah. Well, that's the thing. As you said, you explained it really well, because where the prostate is sitting there round, they're taking out the inside, but the outside is where the nerves are, and they're trying to preserve your function. So, you know, our bodies and cells are very interesting, and they manipulate themselves to do whatever. So I think it's wonderful that you could get back to the same doctor who understood you very intimately in your situation and make that next referral.
Just for purposes of what we're doing here, two things that were kind of interesting as a part of that, and anybody can do this. It's not like, you know, you don't have access today. But realizing it was time to consider, okay, well, you might want to consider radiation. And now this is not going to be medical terminology, so let me be the first to say this, but functionally, in where I live in South Carolina, the option was what I call blast radiation. In other words, it was kind of a wider beam. But I discovered from some research that there is a really highly focused form of radiation that was offered at the Mayo Clinic. And that with a, let me think about this for a second, with a certain type of radioisotope that could be administered, they could do a PET scan that would light up to show exactly where a cancer cell might be. Now, I was all about that. So, And I found that if you pick up the telephone and call, you actually can talk to people on the phone who will talk with you about whatever their particular protocol is.
Yeah.
So I called the folks at the Mayo Clinic, flew up there, sat down. He said, "You're a perfect candidate for this." That's wonderful. Good, we'll submit all the information to your insurance company. Insurance company said, nope, not paying for it. Not medically necessary. It is not the kind of thing that we do here in South Carolina. Now, I'm sitting there like, well, of course you don't in South Carolina because a radioisotope has a 20-minute shelf life. So what are they going to do? Ship it by Federal Express? It'll be dead by the time it gets here. So it can't be done here. It can only be done where the Mayo Clinic has the isotope. Insurance company said no. So from a functional, let me give you the side note to it, which is, by the way, this is my personal irritation, and I'm sure people who are seeing this on video will get this. So I go to the Mayo Clinic and I said, look, if my insurance paid, what would you get? They said, well, you know, it's an $8,000 test to do, and insurance typically pays about 50% of it. Great, I'll pay you the cash for that at 50%. Oh no, you can't do that. Because if you did that, then they'll only give us 50% of what we were accepting in cash, and so we can't clearly do that. So you'd have to pay the full price, and it's like, well, just shoot me. That's just stupid.
It's pretty stupid.
It is. I mean, I feel like I want to have one of those little stools to stand on to say, at what point in time did our healthcare move from the doctor says here's what you need and insurance pays it to insurance deciding what you need and the doctor has to subscribe to the insurance company?
Pretty bad.
Well, anyway, I don't know what that'll sound like, but that was a better growl. Long story short, I ended up having the best radiation treatment that's available where I live and with the insurance company that I have. And the end result was now PSA of 0. So the initial concept of using radiation as a secondary treatment, if it were to recur, I am living proof of working.
Right. Well, the beauty is that our bodies decide what they want to do, and the most skilled surgeon in the world can't find that one little cell that wants to disappear somewhere else.
Sure.
But that is why they follow up and they test. That is why you continue to get PSAs even after you've had the surgery, because most people, I mean, the survival rate 5 years post prostatectomy, if it's caught early, is 100%. 99%, 100%. So that is what you want to do. And to make sure that 5 years later, and you are at about 8 years later when you're seeing something different, you want to keep that relationship. People rest in their comfort and just go back, because if they see it, then they can do something about it.
Right. The one thing that I do recall in talking with a number of radiation oncologists as it relates to prostate cancer was typically the older a person was, if they were in their mid to late 70s, early 80s, radiation tended to be the preferred method of treatment first before surgery. Or if the person was obese and surgery might be more difficult to accomplish, then radiation tended to be the thing suggested. But note for everybody that's watching this, Valda's a nurse, I'm a prostate cancer survivor. The best thing you can do is talk to your medical care provider and make sure that you're comfortable and get qualified medical care. The purpose of this series is not to offer medical recommendations, but to explore in practical terms men's health and prostate health. And we appreciate you being tuned in. We're going to explore surgery in a moment and then talk about what happens following and what you can expect. My name is Chuck Gallagher. Our guest is Valda Ford, and we'll continue our series.